I would like to ask about this genetic testing, which is now currently developed in our country also. So, based on the ethical consideration, do genetic screening in one patient, it must be also screened for the family. I mean the kids and also the children especially also involved in the genetic screening or only in the patient based on the ethical consideration.
Thank you very much. That's very, very important question. And now in our country, it's now under discussion. And for the patient who already have PAH, it's relatively easy in terms of ethical problem because we have the effective drug available, so we could deal with those patients. But the question is the patient who has a mutation but not develop PAH. Sometimes he or she may have some problem in the future for like marriage or job getting. So we have to be very careful. And those genetic counseling is important, but still in our country, those system has not established very well. So that's under discussion.
Okay, another question from the audience, maybe from the middle row. Any question regarding pulmonary artery hypertension? Okay, from the left row, please state your name and the question.
Thank you. My name is Riswadek from JCU Hospital, Jogja. I would like to ask about those who underwent the operation have the poorest outcome. I want to ask about is it any operation or just related to cardiac surgery, and what we need to do to prevent the complication and the poorest outcome for the patient, and do we need to do the echocardiography for any operation or just for the those who want to do cardiac surgery? Thank you.
So do you mean congenital heart disease after operation to develop pulmonary hypertension? Okay. So maybe to Dr. Bulan, so patients with congenital heart disease who get operation and then develop pulmonary artery hypertension, how to prevent this situation, or have you any experience about the congenital heart disease and then operation?
Sorry, let me clear your question. Are you asking about the patient, the general management for patients with corrected congenital heart disease and developing pulmonary hypertension, or how to do the follow-up for the patient with corrected congenital heart disease?
To prevent pulmonary hypertension and patient undergo operation.
Okay.
Okay.
So basically, when we send the patient to surgery or to repair transcatheter repair, we have to do the careful evaluation of the patients in terms of the hemodynamic. So in the case of our unit, because we are the adult unit, so usually we will perform the right heart cath. Most of the patients have the signs of echocardiography, either intermediate to high probability of PH. So in that case, we will do the right heart cath to evaluate the hemodynamic of the patient before we decide that the patient can still be repaired or not. Because as Prof. Emoto previously presented, that what is to be careful is that if the patient is having the genetic tendency of pulmonary hypertension, and the congenital heart disease will be the second hit of the occurrence, the earlier occurrence of pulmonary hypertension. In that case, when the patient is having improportionate, for example, the congenital heart disease is small and then quite high pulmonary hypertension, then we have to see. But sometimes surgeon and also some interventionists will see that the patient is having the pulmonary hypertension primarily due to the congenital heart disease. So that they will do the repair of the defect, and that later we will see the development of severe pulmonary hypertension later after 10 or 15 years. So in this case, in our protocol in our hospital, when the patient is having like simply intracardiac shunt like ASD or VSD closure, during childhood or during adulthood even, especially in the ASD, then we will evaluate the patients after surgery, 3 months after surgery, 6 months, 1 year, and then after that annually. So when you receive a patient from us that we revert back to you after the congenital heart disease, so if you don't have any modality of echocardiography, just do the ECG like every 6 months, and then every year then you can send the patient back to us for having a screening of echocardiography for the development of pulmonary hypertension.
Yeah.
So I think.
Okay, thank
I
you,
hope
Dr.
it's answered.
Bulan. Yeah, because the time is up, I have to close the session. Thank you again for all speakers. And I give the time back to the MC. Thank you very much.
Thank you for Dr. Anggoro, Prof. Noriaki Emoto, Prof. Indah Kartika Murni, and also Dr. Wulan. We extend our gratitude to the speakers for taking the time to present at our event. Your insights and perspectives are truly invaluable. And this concludes the session. We will now proceed to our next session. We will proceed to the next session entitled Palliative and Supportive Care in Heart Failure and Pulmonary Hypertension in Ballroom Tantrum 1, parallel with the topic Streaming with 4 Pathways in Pulmonary Arterial Hypertension in Ballroom Tantrum 3. Thank you and see you in the next session. Commencing the final symposium session of JCU 2024 today, titled Streaming with 4 Pathways in Pulmonary Arterial Hypertension. This session will include 3 presentations. The first, Pulmonary Hypertension Unrevealed, Insights into its Pathophysiological Landscape, will be presented by Real Kusumanjaya Marsam, MD, Cardiologist Consultant. The second, Novel Pathway and Treatment in Pulmonary Arterial Hypertension, Role of the Activin Pathway, will be presented by Professor Noriaki Emoto, MD, PhD. And the third, Miracles Amidst Challenge, Pulmonary Arterial Hypertension in Pregnancy, will be presented by Dia Wulan Anggrahini, MD, PhD, Cardiologist Consultant. This session will be moderated by Dr. Putrika Prastuti Ratnagarini, Cardiologist Consultant, a consultant cardiologist with a focus on nuclear and imaging cardiovascular medicine, and a faculty member in the Department of Cardiology and Vascular Medicine at FKKMK UGM. Dr. Putrika, please proceed to begin the session.
Thank you very much, Dr. Ricky, for mentioning. And now, ladies and gentlemen, we will go to the Symposium 5B. And the first presenter will be Dr. Real Kusumanjaya Marsam. And the topic already mentioned Dr. Ricky, the MC. Dr. Real Marsam is staff at Department of Cardiology and Vascular Medicine, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. Please, Dr. Real, you can go to the podium and yeah. Your time will be 20 minutes.
Ya, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everybody. Okay, yeah, this is my slide because my morning session, I sent the wrong slide to the committee. Yeah, in this session from the committee, I have to present about the pulmonary hypertension, unreveal insight into its pathophysiological landscape. Yeah, we already know that pulmonary arterial hypertension is a multifactorial disorder that associated with severe structural and functional pathological changes. And it's characterized by pulmonary vascular remodeling and a progressive and sustained increased vascular resistance that increase blood pressure in small pulmonary artery. So when we talk about the pathophysiology, the end result is how the pathophysiology can make the pulmonary vascular resistance increase and then make some hemodynamic consequences, not only in the pulmonary vessel, but sometimes they make hemodynamic changes or structural anatomical changes in right ventricular, which is right ventricular dilatation maybe, and until the right ventricular dysfunction. Yeah, from the definition from the European Heart Journal, the pulmonary hypertension based on hemodynamic assessment by the right heart catheterization, and it defined by a mean pulmonary artery more than 20 millimeter mercury at rest. And from the previous session, all the speaker already mentioned about this hemodynamical characteristic. So when we do the right heart catheterization, and we can classify the pulmonary hypertension based on the result of the right heart catheterization. And this is the clinical classification from the European Heart Journal. They divide the pulmonary arterial hypertension in the 5 classification: the pulmonary arterial hypertension, PH associated with left heart disease, PH associated with lung disease, and so on. And I think a lot of patients in the group 1 and group 2 and maybe in the group 3. And the general pathophysiology can make the changes of the pulmonary vascular and in all of the classification. Yeah, this is the pathophysiology of pulmonary hypertension. Actually, the first condition is when there is a trigger in the pulmonary vascularization. The trigger can be genetic mutation, epigenetic factor, metabolic disorder, inflammation, hypoxia, oxidative stress, or vascular injury. And all the trigger can promote a pro-inflammatory and pro-thrombolytic phenotype, and they make the endothelial dysfunction. The endothelial dysfunction lead to uncontrolled cell proliferation, thrombosis, mitigation metabolic change, and they make the remodeling of the pulmonary artery. So and then resulting the remodeling the thicken of the pulmonary artery. Yeah. Endothelial cell dysfunction lead the formation of plexiform lesion, causing the disruption of vascular microenvironment. This is the condition of the vascular remodeling, and in the end, that the vascular remodeling from the pulmonary artery, they can make a progressivity of the right ventricle, and then the right ventricle become the remodeling, just like myocyte apoptosis, oxidative stress, inflammation, the end stage PAH, the right ventricle become dilatation, and maybe the dysfunction of the right ventricle. Yeah, this is the condition of the normal pulmonary artery and the remodeled pulmonary artery. In the normal pulmonary artery, we know that the lumen is still good, the diameter is good, and there is no resistance, or maybe only the low resistance or low remodeling. But in the progressive disease of the pulmonary hypertension, the resistance become increased, the remodeling become increased, and the resulting is the artery become narrow, and more narrow, more severely narrow artery. So this is the condition when the pulmonary arterial hypertension become more severe. The first trigger that I mentioned before is about the epigenetic factor. The epigenetic factor, they make some modification including DNA methylation. And the DNA methylation, this is plays a critical role, because from the DNA methylation, they can make the vascular pathology. The vascular pathology, just like cell proliferation, and make the pulmonary artery become narrow, and progressivity from the for the pulmonary hypertension. Yeah, the second trigger is metabolic disorder. Actually, the metabolic disorder not only, I'm sorry, this my sample is in the patient with metabolic syndrome, but not only from the metabolic syndrome, a lot of metabolic condition can make the remodeling in pulmonary hypertension. And some journals say that the metabolic disorder associated with the pro-inflammatory cytokine interleukin 6. It's contribute to adverse pulmonary vascular remodeling in pulmonary hypertension. But yeah, not only from the interleukin 6, a lot of pro-inflammatory cytokine can also make the progressivity of the pulmonary hypertension. Inflammation also trigger to the pulmonary hypertension. We can see a lot of the pro-inflammatory cytokine that increase in the patient with pulmonary arterial hypertension. Yeah, so I think we need to give more pay attention for this inflammation, the chronic inflammation, because they can increasing the T and B lymphocyte, and then they can make the progressivity of the pulmonary hypertension. The next trigger is hypoxia. We already know that the patient with pulmonary hypertension, they can suffer the hypoxia and maybe the chronic hypoxia. So the chronic hypoxia can increase the reactive oxygen space production, and the ROS, or the reactive oxygen species, can the increasing of ROS or reactive oxygen species can make the pulmonary vascular remodeling, proliferation of vascular smooth muscle cell, and asymmetric neointimal hyperplasia. And combining of this condition can make the pulmonary hypertension. When the pulmonary hypertension becomes severe, that I already mentioned before, that it can make the right heart dysfunction. The oxidative stress that I mentioned before, that oxidative stress in pulmonary hypertension associated with increased production of reactive oxygen species, and the increasing of the production of reactive oxygen species can make the dysregulation of homeostasis. Yeah, so the ROS is increased, but just like maybe nitric oxide decrease. So it's lead to activation of anti-apoptotic and pro-proliferative and make the aberrant vascular remodeling in the lung. So that's the pathophysiology from the oxidative stress in pulmonary artery hypertension. And for the vascular injury, we see that in the pulmonary artery, they become thickening. Yeah, the thickening of the muscular artery can make proliferation, and when the pulmonary artery become thickened, the artery become narrow, so can make the progressiveness of the pulmonary hypertension. So this is that we can see a lot of our patient, that our patient with the left heart disease, heart failure, cardiomyopathy, or valvular heart disease, and this condition associated with the pulmonary hypertension. The pathophysiology combines several mechanisms. The first is initial passive increase and LV filling pressure, because we know that just like maybe patient with mitral valve or aortic valve stenosis or regurgitation, the pulmonary vein, which is the blood come from the left atrium to the left ventricle. When the left ventricle is in the overload volume or overload pressure, the blood from the left atrium cannot go through to the left ventricle, and also from the pulmonary vein. The blood from the pulmonary vein cannot enter in the left atrium, so the LA pressure become increased, and there will be a congestion in the pulmo. And the congestion in the pulmo can make the PA endothelial dysfunction, including vasoconstriction, and become the vascular remodeling. After the vascular remodeling, there will be RV-PA uncoupling. RV-PA uncoupling is how the right ventricle contraction can through the PA resistant, and when the RV-PA coupling is altered, so this is mechanism, or this is the sign that the pulmonary hypertension is severe, and we can see that the patient become right heart failure, swelling, ankle swelling, and so on. And the one of phenotype of the heart failure is heart failure preserved ejection fraction. The heart failure preserved ejection fraction is a little bit difficult for us to treatment, and actually the heart failure preserved ejection fraction is associated with the pulmonary hypertension, and this is the mechanism. Just like my slide before, that the heart failure ejection fraction syndrome can make the LA pressure elevation. After the LA pressure elevation, the passive backward transmission and the endothelial dysfunction in pulmonary artery. After the pulmonary artery endothelial dysfunction, they can make pulmonary artery pressure increase, so they will become vasoconstriction and become RV-PA coupling and then maladaptive RV. So I think the RV failure is the important thing or important sign that the patient suffer a pulmonary hypertension and maybe in the severe condition. Yeah, so this is my take-home message that pulmonary hypertension is multifactorial disease, and based on the definition that pulmonary hypertension, the mean arterial pressure more than 20 millimeter mercury. The pulmonary arterial hypertension can lead to the right heart failure and even death. Multi-biological process such as smooth muscle proliferation, endothelial dysfunction, inflammation, and resistant to apoptosis are associated with pulmonary hypertension. And epigenetic factor, metabolic disorder, inflammation, hypoxia, oxidative stress, and vascular injury play an important role in pulmonary arterial hypertension by regulating the chromatin structure and all the factor resulting progressivity of pulmonary hypertension. This is all for me. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Dr. Real, for the nice, clearly presentation. We will shortly in second session with Prof. Noriaki Emoto with the topic novel pathway and treatment in pulmonary arterial hypertension, role of activin pathway. Please, Professor Noriaki Emoto to come into the podium. Prof. Noriaki Emoto is professor at cardiovascular department at Kobe University Graduate School of Medicine. Prof. Your time will be 20 minutes. Thank you.
Thank you, Chairman. And good afternoon, ladies and gentlemen. Again, I appreciate this opportunity to discuss with you about the novel pathway and the treatment in pulmonary arterial hypertension. And especially, I will focus on the role of activin pathway. And again, this is just repeat as previous talk, but the basis of PAH is pulmonary vascular remodeling. And those remodelings occur by many factors, but one is the most important factor is the TGF-beta superfamilies, which shows here. And these are identified by the genetic studies, including BMPR2 receptor and some other factors. However, the currently available therapeutic approach is 3 these pathways, including endothelin pathway and NO, guanylate cyclase and cyclic GMP pathway, and the prostacyclin pathway. These are considered as vasoconstrictive or vasodilative agent. However, these 3 cannot intervene to the vascular remodeling itself. And this scheme was published in 2023 by Dr. Mark Humbert, but actually this figure has not been changed in this almost 20 years. So definitely we need another pathway to get a better outcome of the treatment. So in our laboratory, we initiated a project to identify the new signaling pathway. And this is Dr. Gusti Rianto from Jakarta. And as a graduate student, he started the new project to identify a gene which contributes to the development of pulmonary hypertension. And I would not go into the detail, but what he did was DNA microarray, which identified the specific gene which is expressed in human lung microvascular endothelial cells and human lung. And we identified, we chose several genes, and finally we focused on inhibin beta A. What is inhibin beta A? Inhibin beta A are translated and make homodimer to make the activin A. And activin family is one of the TGF-beta superfamilies. So we thought that the activin A would be important to develop pulmonary arterial hypertension. So what he did was, by using cultured endothelial cells, the overexpression of inhibin beta A reduced the expression of BMPR2 and inhibit the signaling pathway of BMPR2. And actually, when we get the human sample, human primary culture from the patients, inhibin beta A and activin A are highly expressed in the patient with PAH. And those overexpression of inhibin beta A or activin A induce the reduction of angiogenesis and increased apoptosis. But this is just cell culture. How about in vivo? So we generated mice which express the inhibin beta A or which are deficient of inhibin beta A. So these mice shows that inhibin beta A overexpression causes pulmonary hypertension, and loss of inhibin beta A prevents pulmonary hypertension. So we are convinced that inhibin beta A is important for developing pulmonary hypertension. But this is only just mice. How about human? And actually, this is our collaborator published this paper in Circulation that in the case of human, lower survival rate in patient with high activin A as compared with the patient with low activin A. And with those patients, healthy subject, PAH at diagnosis and PAH at first follow-up visit, clearly show that activin A is important in human PAH also. And again, this is Dr. Chris and Dr. Angolo and Dr. Uran's very beautiful study published from the Gajah Mada University that the congenital heart disease associated PAH also shows the importance of activin A for the development of pulmonary hypertension. So from this study, we thought that the activin A caused the pulmonary hypertension. Then, as a therapeutic approaches, prevention of the function of activin A would be a good the therapeutic approach. So, yeah, of course, many people thought that, and actually, one drug called sotatercept is almost available. And this, almost the same time that we published the activin A study, again, our collaborator, Dr. Mark Ambert, published this paper in New England Journal of Medicine. This is this is a clinical study, phase 2 clinical study using sotatercept for PH patients. In this study, they use sotatercept or placebo on top of the conventional treatments. And this is a kind of astonishing data that on top of those conventional therapy, still sotatercept shows the beneficial effects for PH patients. And this study terminated early because it's too good results. So the next phase 3 study are planned and performed. And this phase 3 study also shows that exercise tolerance by 6 minutes walk distance and major clinical events are also reduced by sotatercept. And sotatercept is relatively safe and well tolerated. The adverse effect of this sotatercept is like increased hemoglobin and thrombocytopenia and bleeding events and increased blood pressure. But there is no reason to stop these sotatercept because of these the adverse effects. And sub-analysis shows that this drug resulted in the echocardiographic right ventricular function improvements and by using the TAPSE or change in RVFAC and these parameters. In addition to that, sotatercept increased the exercise capacity and improvement in clinical WHO functional class after treatment. So on top of the conventional treatment, sotatercept can improve the symptoms, QOL, quality of life, and survivals. Based on these findings in the States and Europe, sotatercept has been already approved. And in Japan, it's not on clinical trial, but we expect that this drug would be available next year. So this is again the 7th World Symposium on Pulmonary Hypertension, and in June. And the new the algorithm for the treatment, as shown here, this activin signaling inhibitor means sotatercept would be used for intermediate or low risk or intermediate high risk or high risk patients. So nowadays, for the treatment of PAH, not only endothelin pathway, nitric oxide pathway, and prostacyclin pathway, activin BMP pathway would be main. So one of those main therapeutic targets. Then, what's next? So, since we have been working about the endothelin system, we are interested in the interplay among those pathways. And Dr. Novia, who is a graduate student in the laboratory, and she is working about the relation between the endothelin pathway and activin pathway. And again, she found that the activin pathway is upstream of the endothelin pathway. So if these data are true, we should use sotatercept before using the endothelin receptor antagonist. And if it's not enough effective, then we could add endothelin receptor antagonist. So she's now trying to find the mechanism of these effects. And other than the activin pathway, many laboratories are focusing on identify the new pathway, and these are one of those summaries published by Dr. Gorfani in Nature Review Cardiology. And imatinib, this is the thyrine kinase inhibitors, has been already shown that effective for the PAH, but because of the adverse effect, the fatal adverse effect, this has not been applied to the clinical setting, but those pathways could be one of the important targets for the treatment of PAH. And other than that, several pathways, and including metformin, could be effective. So to conclude my study, the therapeutic approach targeting the activin A signaling pathway, including the use of sotatercept, is anticipated to become an effective new treatment for pulmonary arterial hypertension, in addition to the existing 3 classes of medications. And finally, I would like to introduce the many Indonesian colleagues of our laboratories. You may identify several people, of course, including Dr. Anggoro and Dr. Anggoro and Dr. Uran, and many from these countries. And this is the current members of my laboratories. Dr. Gusti is now the assistant professor of my laboratory, and Dr. Indi is now a postdoc, and others are the graduate students in Kobe universities. And because of the hard work of these very young, talented researchers, we can be very productive. Thank you very much for your attention.
Thank you, Prof. Noriake Emoto, for the nice and interesting presentation. Please, you can go near Dr. Real, and then next speaker will be Dr. Diah Wulan Anggraini with the topic Miracles Amidst Challenge, Pulmonary Arterial Hypertension in Pregnancy. Please, Dr. Diah Wulan Anggraini. Dr. Diah Wulan Anggraini is cardiologist consultant of interventional cardiology, and she's staff in cardiology and vascular department, Faculty of Medicine, Universitas Gadjah Mada. Dr. Wulan, your time is 20 minutes.
Thank you. Good afternoon. So, how's the blood glucose? Everybody? Still enough for the last session before we have the closing ceremony? Okay. And who wants some door prizes? Feel free to raise your hand. So we have a miracle admit challenge. What is it? It's a miracle in between heavy challenges about the pulmonary arterial hypertension in pregnancy. Again, I have nothing to disclose. So we have a female, 28 years old, with diagnosis of ASD and PAH. The BP is still good, heart rate good. Oxygen saturation is slightly decreased, it's 95%. So do we need an oxygen supplementation in this patient? Yes or no? Who is yes, who is no? Yes? Raise your hand. Nobody? No? Raise your hand. Everybody lack of glucose, I think. So we see the ECG. Again, if you work in primary care unit, you see the ECG, it's right axis deviation, and it's a sign of right ventricle hypertrophy. I already explained to you in detail how we diagnose with pulmonary hypertension. So you see the chest X-ray. This is very typical of a chest X-ray in which if the patient is having ASD, so she confirmed with ASD, severe pulmonary hypertension because they're very enlarged pulmonary arterial canals and well, the signs of already pruning or the probably she already have a right to left shunting because the oxygen saturation is only 95%. So this is the echo, very severe decreased eccentricity index. Tricuspid regurgitation, can you see the valve gradient is 115. So if we measure the RVSP is probably 120. And the TR velocity is 5.3 meter per second. So then we perform right heart cath. You see, oh my God, the mean pulmonary artery pressure is 64 millimeter mercury. I don't know how she survived, but thank God she's having an ASD. So while, with having an ASD, so the shunt can be reversed, then the patient up to this stage, she's asymptomatic or probably less symptomatic, or probably you didn't catch her symptoms well. And the NT-proBNP is 750. One day, she came to my outpatient. She said, I got married last year. And then, oh, sorry, where's my, she's missing. Okay, she came with her first pregnancy, 8 weeks, no history of abortion. She's happy, I'm crying. With the transvalvular gradient of 115 millimeter mercury, how can I say to her with her pregnancy? What should I say? I already told her from the beginning, when she come to me with, I will get married. And I say, okay, of course you can get married, but don't get pregnant. Because that could be devastating. You might be happy, but I will be crying. That's what I told her. And then I sent the patient to the obstetrician. The obstetrician, what did the obstetrician say? Oh, this is just 8 weeks. So this is your consultation to us. I will follow what you want from us. Because they absolutely have no idea what to do with the pregnancy with severe pulmonary hypertension. And then we have to come to a clinical conference inviting the anesthesiologist and also the medical ethics. If you were in my position, what will you do? How many of you have ever been faced this kind of patients? Maybe, can you raise your hand? 1, 2, even? No? Okay, 1. I have one who doesn't have a glucose insufficiency. Well, just at a glance, so congenital heart disease, the first diagnosed at reproductive age, 60% of those is probably having pulmonary hypertension. That's the data from our center. And in general, the maternal mortality of patients with pregnancy with pulmonary hypertension will be reached up to 10 to 38%. So yeah, this is again the adult congenital heart disease registry in our hospital. It's about 2,400. 84% is having pulmonary hypertension. You can see 76% is female. And you can see 70 to 40 years old of the patients. So you can imagine that the patient is in productive age or female productive age. So we will face this problem in like a daily, and you know our culture in Indonesia that once they get married, everybody in the family will ask, when will you have children? When they got the first children, when will you get the second children? Etc. And the pulmonary hypertension, this is excluding congenital heart disease, we had 81%, so I think you already see this from my previous presentation. And in pregnancy in women with pulmonary hypertension, the mortality rate in other registry can be, is reported can be 30 to 56%. and the fatal death is 11 to 28%. So you can imagine what is the burden. Yeah. This is the maternal adult congenital with pulmonary hypertension. We have congenital heart disease about 379, and 9% of them are Eisenmenger. And again, about 60% to 70% of them are having pulmonary hypertension with a quite variable degree. And 6%, and we have a mortality rate of 6%, which is quite good. And the predictor of patients of uncorrected congenital heart disease in our patients, mostly due to pulmonary hypertension, is you can see here, the tricuspid valve gradient and RV systolic pressure is some of the predictor of the mortality in the pregnancy of adult congenital heart disease uncorrected. And some of them is having heart failure that even worse, make the worst prognosis of the patients. And this is a work of one of our graduate students showing that Eisenmenger syndrome, NT-proBNP level, and NIHA functional class are significant factors associated with mortality in pregnant women with adult congenital heart disease. And also the occurrence of right heart failure, the presence of pulmonary hypertension is also significant. And when we do multivariate analysis, apparently the baseline of NT-proBNP level during pregnancy and also the right ventricular pulmonary artery coupling, which is a prognosis in pulmonary hypertension, is significantly are the two factors that associated with the mortality in our patients. So again, when we deal with pregnancy in pulmonary hypertension, we do the modified WHO classification for the risk stratification. And once the patient is diagnosed with pulmonary hypertension, especially the severe one, then the risk stratification of the patient is a maternal WHO class 4, in which the mortality rate can be extremely high, as extreme as 100%. So the basic understanding on physiological changes in pregnancy and also in pulmonary hypertension, as you see, by the increase in trimester, there will be changes, significant changes in the hemodynamic. You will have increase in cardiac output. You probably will have a low blood pressure, but later in the third trimester, you will have an increase in BP, and the heart rate will be increased because your sympathetic tone will be increased, the systemic vascular resistance will be decreased. And all of these changes occur, the extreme occur usually in between the first and second trimester. And when the patient or the female, the woman is having pulmonary arterial hypertension, there will be a huge changes because we already have abnormality of the compliance of the heart because of the pulmonary hypertension. So the pulmonary compliance is decreased, and the increase in pulmonary vascular pressure during the pregnancy might be occur. Once the pulmonary artery pressure increase, then there will be a decompensated or the remodeling or right ventricle. The right ventricle will be enlarged, and there's a probability of the decrease in the compliance of the right ventricle. Thus, there will be a leftward shifted of the interventricular dependency, in which it will decrease the left ventricular filling pressure and also decrease in the cardiac output. This all mechanism explain why in patients, in pregnant patients with pulmonary hypertension, the hemodynamic decompensation can be accelerated as compared to those with non-pregnant. So some contributors to the pregnancy-associated right heart failure in women is one is the increase in cardiac output. And in pregnancy, we know there will be a hypercoagulability. So the increased chance of occurrence in a thrombosis, in vein thrombosis, will be increased, especially in the occurrence of deep vein thrombosis and also the pulmonary embolism. And there's a decrease in systemic vascular resistance. In this case, the patient is, will be this condition will be disadvantaged because the cardiac output will be decreased, and there will be increase in arrhythmia, not to mention there is increase in sympathetic tone and pulmonary hypertension, both combined to increase the rate of atrial arrhythmia at the mildest consequences. And also the labor and delivery. I will explain later about this. And during the postpartum, because the changes, the acute or sudden changes in the plasma volume and will be increased in the right ventricular work with the high pulmonary arterial pressure, there's a lot of changes that might occur. And it will increase the risk of right ventricular failure and also malignant arrhythmia. So the maternal death may occur in the last trimester of pregnancy and in the first month after delivery. So the highest rate of the mortality in the peripartum area is the first week to the first month after delivery. And the causes are the first is pulmonary hypertension crisis, pulmonary thrombosis, and also refractory heart failure, or that it's very difficult to maintain. Thus, it is recommended that pulmonary arterial hypertension, female with pulmonary arterial hypertension to avoid pregnancy. Of course, it's not keharusan gitu ya. It's not compulsory. We can also stratify the pregnant woman with PAH. So those who have a well-controlled PAH with PAH-specific therapy with a lower PVR have the lower risk of outcome of pregnancy. And those with uncontrolled pulmonary arterial hypertension or those who come, the initial visit is at the third trimester without any previous pulmonary arterial hypertension therapy will have a high-risk pregnancy. The second, what we have to do is doing the risk stratification for those with female with PAH. Ideally, for female with pulmonary arterial hypertension, we have to do a pre-pregnancy counseling. So if you deal with patients with PAH, so please advise the patients at least to do the stratification before they undergo the pregnancy. And if the patient is having severe pulmonary arterial hypertension or uncontrolled pulmonary hypertension symptoms despite the optimal medical treatment, then the patient is actually having a harmful condition for going through pregnancy. And before pregnancy, we advise to perform the risk stratification. This is quite easy because you just do the WSO functional class, 6-minute walking distance and NT-proBNP level to evaluate the intermediate low, intermediate to low, and also intermediate high, and as well as the high risk condition. And if the patient is having intermediate or high risk profile plus RV dysfunction, we would advise the patient to do the early termination of the pregnancy. If the patient is having low profile and the patient is just clinically well with normal functional capacity, then counseling and shared decision-making with the family and as well as all our colleagues from other disciplines will be necessary. So this is what we usually do when we have patients, PAH patient with pregnancy, we will do a multidisciplinary conference. So if a woman became pregnant, do the counseling, and if it's the condition is intermediate to high risk with a sign of RV dysfunction, we will consider the therapeutic abortion. Well, of course, the right heart cath is can be done, but preferably if we can do all the parameters by echocardiography, and we think if this is sufficient, then we will just do the stratification by echocardiography to avoid the risk of the radiation to the fetus. And if a patient, PAS patient conceive on targeted therapy, then we have to consider to withdraw all the drugs that is considered teratogenic and taking only the safe drug for pregnancy. We will also explain it later. And therapeutic abortion is recommended before 22 weeks of gestation because the risk of post-delivery to that patient will be similar after 22 weeks. The risk of the delivery will be similar to those at the third trimester. So back to our patient. After having the conference, the patient is advised for medical termination to do the severe phenotype of the patient. But again, since we are living in the east part or southeast part of this world, so Well, culturally, most of the patient usually will be decline of the advice for the medical termination. So again, we do the multidisciplinary termination, do the schedule follow-up for the patients. Yeah. What we do is we having the monthly visit